also I would just like to caution you, the ceiling above is glass, it's mirror. We can even see what messages you are sending to one another on the phone. So be careful. Okay, a lot of what I had to cover has been actually covered by Dr. Sanjeev already. So first of all, I would like to thank IHMR for inviting me here to talk to you about the topic was actually diet and non-communicable diseases. I will not really dwell too much on diet. I'll talk more on nutrition simply because I don't know, many of you must have heard this story. Actually, Gandhiji was once told by a mother that my child eats a lot of sweets, so please go and tell the child it's not good to eat so much sweet. Apparently, Gandhiji took a month before he went and actually told the child, don't eat so much sweet. So when the mother asked him, why did you take so long? He said, see, I personally eat so much sweets, I had no moral right to advise people when I can't follow it myself. So I will not advise on diet because I cannot follow it myself. So I will touch upon it more from a life course perspective rather than just a diet or a nutrition. And since I come with this maternal, infant and young child nutrition background, I will also touch upon the undernutrition part of it, how it links to non-communicable diseases. I think we have already heard this, I won't repeat any of this. Only thing is that we often hear about this double burden or the transitional diseases. It's very common to see in the same household having an undernourished child or a stunted child and an obese woman. So you have overnutrition and undernutrition lying side by side, and morning we already heard about these comorbidities that exist in each patient, in each household. So I think we already have this double burden. In fact, somebody had also described this as triple burden because we also have a not very effective healthcare system, so there is also that lack of care that comes along with this double burden. And once upon a time, all NCDs used to be something to be proud of because it generally affected these elite, the rich, the urban people. It's no more the case. In fact, more and more lower income households are being affected by non-communicable diseases. So, we talk about chronic diseases over the life course, and this is not life cycle because generally when we say life cycle, we limit it to this reproductive cycle where we have an adolescent girl, a mother and a child. Somehow we can't go beyond that. So we are talking about a life course here. There are many models that have been taught in this life course which are kind of overlapping, where some insult may occur at some particular point of time, or there may be more than one insult which may add to one another and lead to development of different chronic diseases. So these are some of the components in this life course which Dr. Sanjeev also mentioned, that is the fetal development and maternal environment, infancy and childhood, adolescence, adulthood, and aging and older populations. And at each stage of life, whenever there is malnutrition, which could be undernutrition or overnutrition, it could in some way or the other affect the person's health, leading to non-communicable disease. And of course, all of them come under the socio-economic factors where you have poor, fried foods being eaten, pollution, and lots of sedentary lifestyle, stress. In fact, my very dear friend today, Tuhina, who's been with me since morning, as soon as I came from the airport, she said, Madam, everybody wants to listen to this NCD that added so much stress to me. I didn't know how I was going to satisfy, I don't know what you were looking for anyway. So, stress is one very important factor. And just to touch upon a little bit about the fetal development and the maternal environment. Intrauterine growth retardation, which is the reduced fetal growth, can lead to metabolic syndrome in the middle age. And metabolic syndrome is basically, I'll just come to that. And also overnutrition in utero has been shown to be linked to increased risk of cardiovascular diseases and other NCDs later on. This the undernutrition in utero is supposed to be due to this. This was this Barker's hypothesis, which has become very famous. That is the fetal origin of adult diseases. It is called a 50 phenotype, wherein when the fetus in the uterus is exposed to a nutritional condition where the mother herself is undernourished, the programming of the infant, the fetus is in such a way that it is a kind of the mother's environment gives it a forecast of what it is going to have throughout its life. So the child's programming is in such a way that when it comes out, if it by chance ends up receiving more than what it had expected, it leads to the programming going awry, and the metabolic syndrome is supposed to result from that. Yeah. This is the theory behind this 50 phenotype hypothesis, where the maternal undernutrition programs the fetus, and then you have multiple organs going into this. See, because the vital organs are to be rescued, and brain is considered the most vital organ, so all other organs kind of compromise so that the brain can develop. And in infancy and childhood, we have breastfeeding, of course, we've been hearing about the multiple benefits it provides the child. And one of them is also a breastfed child as against an infant formula fed child is supposed to have lesser risk of blood pressure even in childhood and later on in life. And postnatal growth, this is something very kind of confusing, because we always say if a child is born underweight, that is the low birth weight at birth, and after that if the child has this catch-up growth, if the child gets the right kind of nutrition, the child is supposed to be up to the age of 1 year and maybe 2 years. If there is a catch-up growth, the risk does not increase in adulthood for NCD. Whereas if the catch-up growth occurs later, then the risk of NCDs increases. Similarly, a stunted child also, when the nutrition, because stunting, I hope all of you know, stunting is basically hyper age, which is supposed to be a chronic undernutrition, and the height that is lost when the child is stunted within under 2 years of age cannot be made up however much you may give the child nutrition later on. So a short child, when they increase weight, then you always have a body mass index which is higher, which leads to the risk factors. Then of course adolescents and young adults, but it's a very critical age group, because first of all a number of risk factors start appearing at this age, starting from acquiring the wrong habits, and also these habits once acquired at this age generally tracks you for the rest of your adult life. So it's always prudent not to start bad habits, and adolescents, despite all the risk taking behavior, you must be cautious about not really developing these things. And adulthood, again Dr. Sanjeev has already covered. We have a lot of risk factors which are already there. I will not go into this again. Then aging and older people. Just want to note, aging and older people require treatment and care, but we often say there's no point doing any lifestyle modification now. Age ho gaya. But that is not the case. Actually, at any point of time, every time you reduce the risk, there is some benefit to the patient. And Dr. Sanjeev had already mentioned a few facts about what is the status in India. This is specific to the data that was collected by the National Institute of Nutrition through their National Nutrition Monitoring Bureau survey in 2006, and it was for hypertension in rural areas. It's very surprising, 25% of the men and 24% women, were hypertensive, and highest was in Kerala. It was almost, I think, 45%. And there was a strong correlation between obesity, waist hip ratio, and the waist circumference. 4% of men and 2% women were diabetic, And abdominal obesity by the criteria of this thing was 25% in men and 69% in women. And most of the households belong to not very elite socio-economic status. These are some of the tables that want to be seen. Just wanted to see that you can see the prevalence of hypertension in all these communities, and they are all linked to abdominal obesity and overweight. This is something interesting. I don't know how to make those circles and all. But if you see, we always somehow expect only sedentary occupation to be having hypertension or anything. If you see, even the labor class, 22% of the labor class had, and this was a higher sample size also, 22% of the labor class also had hypertension. And so it is not, I mean, the lower classes are not spared from these. So these are the risk factors we have already talked about. This is just to tell you how with each addition of risk factor, how the 10-year risk of a fatal or non-fatal cardiovascular event increases. This is the left-hand side is the age in years, niche jo diya hai, that's the cholesterol, and top is either with diabetes, and the next slide will be without diabetes. As you see, as the risk factors accumulate, the cardiovascular event risk goes on increasing into red. This is for without diabetes. This also Dr. Sanjeev has already talked about, the Global Action Plan for Prevention and Control. It is, a vision is a world free of the avoidable burden of NCDs, because you can't really eradicate. People have to die, so they have to die with some reason. And we need a right course approach. We have to have empowerment, and there's lots of evidence-based strategies that we need to approach. And like we also mentioned, multi-sectoral action. And some of the best buys, that is the most cost-effective strategies that have been advised. I don't know whether you can see it. It is for tobacco use, harmful use of alcohol, unhealthy diet and physical inactivity, cardiovascular diseases and diabetes. There are some simple things that can be done which give the best return on investment to be. And this is what Dr. Sanjeev was talking about, the 25 indicators. They have indicators for different things, for the mortality, then we have for behavioral risk, we have for biological risk, and for the national system. So basically what we want to say is unhealthy diets, all these are confirmed risk behaviors. Major biological risk factors emerge and act early in life and continue to have a negative impact throughout the life courses. This also was a slide you already showed us. This was the action framework that the Lancet came up with in 2013, and basically it talks about, we are looking at it from the child undernutrition and the maternal undernutrition point of view. And the NCDs as one of the long-term consequences. It has at least been recognized. Because if you see the WHO documents on NCD prevention, we hardly talk about undernutrition in children. But in Lancet, when we talk about the action framework, we say consequences of maternal undernutrition, these are long-term NCDs. This is just to tell you why it is important to have in nutrition. Maternal nutrition is very important for a child to grow well in the uterus. Once the child comes out for 6 months, the child is only given exclusive breastfeeding. Following which comes what all our data show, after 6 months till 18 months is when the malnutrition rates start peaking, because they don't get the right kind of food. The problem with children is they can eat very little, their stomachs are very small, so when you give them very little, it fills up their stomach, so the quality has to be energy dense and nutrient dense. And what we have seen is most of the family foods that are given to children cannot fulfill the needs of the child, particularly iron and zinc. So the child, these are some of the models that they were tried out using non-vegetarian foods, vegetarian foods and different cereal-based foods. It was found that none of these diets could actually provide the child what it needed. Last slide. So what are the options we have? One is of course the good maternal nutrition, and we also have appropriate IYCF practices. And under complementary foods, it's very easy to say you can all make it at home, but it's easier said than done. So we need to have some option for providing either fortified blended foods, which we have under the government ICDS program, or the new thing that has come up is multi-nutrient powder called sprinkles, and sprinkles is a trademark, which is just a white color, white tasteless powder that can be mixed with any family food that will give a 1 RDA of the vitamins and minerals needed for the child. This is supposed to be working very well in other countries. Bangladesh is one of the biggest adopters. India, we haven't adopted it for some strange reasons. That's it. Thank you very much. Have a nice day.
Thank you, Dr. Sadhana, for keeping pace with the time. You have really done a remarkable job. I must thank you again and again. And this allows us some questions. If anyone of you are, especially the students, if you have any question, we have a couple of minutes to deal with. Yes, please.
Good afternoon, ma'am. Good afternoon, sirs. I'm Dr. Kansha Sood from the Reimaging University, second year. Ma'am, so my question is that it is clearly evident from your presentations that the burden of non-communicable diseases is higher on the lower socioeconomic strata. Is it because of the delay in screening or diagnosis that this burden is increasing in this lower socioeconomic strata, or is it the difference in the prevalence rate itself amongst the higher socioeconomic strata and the lower socioeconomic strata? Thank you.
Part of the reason why it is higher is, see, most of the things when it happens, it starts in the higher segment. Even for non-communicable diseases, when it started among the higher socioeconomic groups. But at least we have access to knowledge, awareness, and also to take action against it. So you know how many gyms have come up in every locality and how we have started talking about organic foods and excluded food. Whereas when it goes to the lower socioeconomic, one is their exposure to risk is also higher. Smoking is high, all the risk factors are higher. Their access to healthcare is also lower, and access to the protective services like you can call. So that is part of the reason why it is also going to, and of course the late diagnosis, because even in that NNMP survey it was found that almost 64% didn't even know that they had hypertension or diabetes. So that is also part of the reason, and if you want to add.
Thanks, I think you have covered everything. I just want to add one. Low birth weight is higher in lower socioeconomic status, and she talked about Dr. Barker's hypothesis that children who are born low birth weight are more likely to have metabolic diseases in later life. And then other mechanisms of coping, people who are better off can cope, their awareness to healthy lifestyle, their adoption of healthy. You don't see a laborer doing a jogging in the morning, but you see a lot of middle class people doing that. They don't get time, they're old